good evening, everyone. I'm really excited to be part of this wonderful webinar about an important issue that we have in the ICU for all intensivists is the asynchrony of patient ventilator asynchrony. And today we'll talk about a very important study, actually has been done and published at 2026, just recently, 2 months ago. And we have the chance today to have 4 of the authors, and we will be able to discuss with them and to interact with them. And this SYNAPsE Delphi Consensus webinar has been organized between the PROVE Network, the PVI Network, and the Critical Care Network Africa and Middle East. And I'm delighted that everyone can join us and learn more about asynchrony patient ventilator. With me, I have as well the chance to have Professor Denise Battaglini and Dr. Ahmed Al-Masri to join me as moderators. And I will let Professor Denise Battaglini to introduce our first speaker, Dr. Aurora.
Good evening, everyone. It is a pleasure to be here with you. It's now my pleasure to introduce our distinguished speakers. The first speaker is Professor Markus Schulz. He's a professor in intensive care medicine at the University of Amsterdam and Switzerland. He's established in the laboratory and experiment intensive care and anesthesiology, member of intensive care research and founding member of the Proven Network, which is very well known around the world. It is also a founding member of Critical Care Asia and author, of course, of the SYNAPsE Delphi Consensus. The other speaker is Professor Juliana Ferreira. She is a professor of pulmonary critical care at the University of São Paulo, Brazil, associate program director for the Pulmonary and Critical Care Medicine Fellowship, ATS MECOR Latin American program director, PROVE Network board member, and of course, author of the SYNAPsE Delphi Consensus. Then we have our other distinguished speaker, which is Professor Prashant Naza, anesthesiologist and intensivist and clinical researcher in critical care medicine. He works at the Department of Anesthesia and Critical Care Medicine, New Cross Hospital, the Royal Wolverhampton. In UK, he is actively affiliated with the Department of Intensive Care Amsterdam. He is known for his research in RDS, mechanical ventilation, and Delphi methodology. He's again a Proven Network board member, International Fluid Academy board member, and of course a SYNAPsE Delphi study methodologist. Then our last speaker is Dr. Laura Buiteman. She is a research associate in intensive care at Amsterdam, the Netherlands, Proven Network board member, and her academic works focuses on mechanical ventilation, closed loop automated ventilation. So additionally, interest in mechanical power, ventilator-induced lung injury, and patient ventilator asynchrony. She's also a corresponding author of the SYNAPsE Delphi Consensus. Welcome to everyone.
Dr. Ali, you're muted. Dr. Ali, you're muted.
Sorry again. That's always a problem with the webinars. So I just want to thank everyone here to be part of this webinar, the speakers, the moderators, and of course the attendees. And I hope it will be very fruitful for everyone. So I think we'll talk about the study purpose, and you can see that we have 4 of the authors here, and it has been, I think, a very important and long study. and we'll start directly with the last author, Laura Whitman. I have a few questions for you. So I just want to ask you, why have you done this study and why it has been done now? I think it was started maybe 1-2 years ago and one now. And what were the goal, the aims of the SYNAPsE study?
Well, thank you, Dr. Ali, for these questions. But first, I would like to thank you all for organizing this webinar, and thank you for having us and invite us as an author group. It's very nice to be here. So why we did this study and why now? Those are actually two very good questions. And well, why this study? It's true we started, I think, like 14, 15 months ago, because consensus with the Delphi methodology takes time. But I think I'm sure Prashant will explain this all in a later question. But why we did the study is, well, we had a clear motivation because, well, there's actually a mismatch between what we know about asynchronies and what we are actually doing and using in the ICU and daily ICU practice. Because we already know from, well, I think lots of research already that asynchronies are quite common and well, also associated with important patient-centered outcomes like prolonged ventilation and mortality, the incidence of ventilator-induced lung injury. But at the same time, we know that it's frequently under-recognized in daily practice at the bedside. And well, we think that the major reason for this is simply that patient-ventilator asynchronies are quite complex. The complexity of it is that asynchronies are diverse. They have physiological causes, but the waveform patterns to recognize them can be very subtle. And well, reliable detection requires actually continuous attention, but also clinical experience. So in a busy ICU with high workload, multiple priorities, and limited time, well, it's not feasible to well, to have those continuous monitoring and recognition. And at the same time, well, literature is also fragmented about asynchronies because some studies suggest that certain asynchronies are linked to those worse outcomes, but sometimes evidence is inconsistent. And well, many other asynchrony types are, well, not so well studied. So this leaves us with an, well, quite important and unanswered question. Are all asynchronies equally relevant, or are some clearly more important than others? So that was, well, why we did the study. There's no shared no good framework to guide prioritization of patient ventilator asynchronies. So, and why we did the study now, or actually we started 1 year ago. Well, we are noticing that we are entering a phase that we can use in the near future, automate the detection, perhaps, of ventilator asynchronies and artificial intelligence use. They are actually rapidly developing. But I think that these tools can only be useful if we first define what actually, well, matters in clinical practice. Which asynchronous should be detected and which one should be perhaps prioritized. Because without that, I think we risk that some people are building high sophisticated systems, but it could not be aligned with clinical needs, actually. And I think we all know that we having in intensive care medicine having an increasing shift to personalized ventilation, more and more lung protective ventilation. And if we want to move in that direction with patient ventilator asynchronies, I think we need a better understanding, well, of which asynchronies are potentially more harmful than others. So I think this is already a very long story.
Thank you so much. So yeah, it's a real issue in the ICU, but yeah, as you said, is under-recognized, and we have to agree together as a community of intensivists what what can we call ventilator asynchrony, and we have to name them in the same way, just to approach them in the same way. And I understand this, it was very important, and thank you for be part of this study and leading that, and to provide us some guidance for clinical practice.
Yeah, of course, it's our pleasure, and I think it's we think it's a very important first step to have more clarity, more guidance.
So who did decide the first to go with this idea to go on a consensus, or it was a discussion between you and Professor Marcus, or how just want to know behind how it started?
Well, of course, we are all members of the PVI Network, are all the authors here. And Prashant is a very experienced Delphi methodologist, working already closely with Marcus. And yeah, it was just a brainstorm idea with Marcus, with Prashant, because asynchronies are it's highly relevant, and there's more and more attention to it, but there is no causal evidence. So we thought, thinking of all our other Delphi studies, that this would be a very first step. So yes, it starts with an idea, and then it's ending with this nice publication.
Excellent, thank you so much. So maybe we'll give the chance to Denise to ask Professor Marcus about a few questions.
Yes, thank you. I have a question, yes, for Professor Marcus. So let's now focus on the gaps in recognizing and monitoring patient ventilator asynchrony in everyday ICU practice. So what are the main reasons for PVA to remain under-recognized in daily clinical practice?
Thank you very much, Denise, for this question. And let me also thank you, Ali, Ahmed, and Denise for organizing this. It's really appreciated to have this meeting. And I would also like to thank Manon Molenaar, the first author of the publication. She did most of the coordinating work of this project. And of course, the panelists that were very important, because we used their knowledge actually to come to the conclusions. Coming back to your question, Denise, actually this is for me, or it was for me, the reason to start this Delphi, because I got very, very frustrated over the last 20, 25 years that we always tend to forget that there are PVAs, that we do not recognize PVAs, and putting all reasons together, I think there are mainly 4 reasons. One of them is because they are subtle, they are not easy to find at the bedside. They really require, and that's the second reason, a skilled eye, which is often lacking. It needs attention. You really need to pay attention to it, and the tools that are there to recognize them are rarely used, and already alluded to by Laura, there are now new tools coming up. We're not sure how good they will work and how they will improve the recognition after all. So this is in a nutshell, I think, the reasons for why it is often under-recognized. To put it a little bit in more perspective, as I already said, they are quite subtle. They are not always clearly foundable on the ventilator screen. Some ventilator screens do not show them at all, or do not show, for instance, the ventilator waveforms, but the waveforms themselves are also not very helpful in this respect. Actually, it's quite often that there are patient ventilator asynchronies while the waveforms look quite normal. And that is the problem with this trained eye, I think. I think it's not new for everyone when I say we are working very hard in ICUs. We're taking care of many different processes, and then this is really one of the last things we're usually focusing on, if we are focusing on it at all. And things like PESO and other tools to recognize patient ventilator asynchronies are hardly used, or people do not know how to use them very well. And then actually we are ending up in a situation in which we say, you know, there might be PVAs. Maybe they are important, but I cannot recognize them and I don't even know what to do about them. And it often ends up into a decision like, let's ignore them, or worse, maybe paralyze the patient and all the PVAs are suddenly gone. This would be my answer. There are probably more reasons why it's under-recognized, but Denise, this is what I think the main reasons are for under-recognition of PVAs.
Thank you, Marcus, for your answer. It is very clear. I would like to ask Dr. Laura, what gap did the SYNAPsE study aim to close?
Well, actually, there were two gaps, or three gaps. One, the first gap, or the first aim, was that we wanted to identify and to have consensus on which asynchronies could be reliable detected using standard ventilator waveforms. So most of the time in asynchrony research, there's the use of an esophageal pressure balloon with transpulmonary pressures. But in clinical practice, it's not often used, and we mainly rely on just the standard pressure, flow, and volume waveforms. So we would have that consensus on which asynchronies could be reliably detected using those standard waveforms. And second, of course, there's a lot of interest in which asynchronies are most strongly associated with patient-centered outcomes. So we would want to have those consensus on that, and not only in patients with ARDS, because research is mainly focusing on patients with ARDS, but of course we have a lot of more patients in the ICU, definitely not only ARDS. So we also defined it in patients after cardiac surgery, because it's a large group where asynchronies are often appear, and also a larger group like patients without ARDS, or you can call it critically ill patients. So for each group, we focused on outcomes that matters for that specific patient group. For example, in patients after cardiac surgery, we focused also on discomfort, because those patients are rapidly getting awake, and they could have some discomfort from asynchronies. So, and the second of the third aim, so the third gap, was to create a hierarchy of asynchronies based on clinical relevance and their severity, also in those three patient groups, so patients with ARDS, without ARDS, and patients after cardiac surgery. So of course we did this with Delphi, and we emphasized also in the article that this is not meant as a final answer or something, but it's rather a first necessary step to standardization, to more clarity, to have more of the theoretical knowledge having used in clinical practice.
Yes, indeed, you did a great job in this sense. So stepping to Marcus again, I would like to know what are the consequences of relying mainly on ventilator waveforms without advanced tool for PVA detection? Can you, Marcus, give us your opinion?
Thanks, Denise. I think this is a very important question. Let me start with something good, and that is that the panelists agreed that using waveforms can help recognizing PVA. So actually, we try to identify those PVAs that can be recognized and should be recognized using waveforms. But the problem, of course, is that using only waveforms is still leading to underestimation of PVAs. It leads to misclassification, and with that, a delayed response in busy ICUs. And as a result, some of the clinically important asynchronies may be missed totally and not be treated at all. Let me explain this a little bit further. I think when we are relying only on standard ventilator waveforms, this leads to an underestimation simply because some of the events are easily missed when you're only looking at waveforms, simply because they're too subtle. You really have, what I already said at the beginning, a trained eye to see when asynchronies start to develop or when asynchronies are there. The second thing is that using waveforms is not the whole story. It's not telling us everything. For instance, missed efforts by patients or missed activities of a patient, we cannot do that with waveforms all the time. So we need PESO and maybe other tools to recognize that the patient is doing something different than what the ventilator is responding to, right? This is actually a PVA. So relying solely on ventilator waveforms is to a certain level possible. It's a poor man's solution maybe, but it's difficult. Subtle things may just get lost, and with that, treatment is incorrect or is maybe even not given. And I think this is something we will discuss a little bit later on, like what is needed beyond this. But again, the clear answer is we can use waveforms, and some of the PVAs can be recognized using waveforms, but it is coming with, well, the risk that we simply missed important ones.
Thank you, Marcus. I believe maybe other moderators like Ahmed wants to take the lead now.
I have a question to the study methodologist, Dr. Prashant. Many of us, as a participant, they don't know about the Delphi study. So what is the Delphi study and the methodology, how it works, and how you do the consensus for the study?
Thanks, Ahmed. I think it's a great question. But before I answer this question, I would like to again thank Ali and Denise for, first of all, not just for the nice introduction, but also having us here to discuss such a complex study, because I remember that we had a lot discussion on the background why we should go for a Delphi. PVAs are well known. There is a lot of evidence which is there, but at the same time, when the evidence is there, does it give you the right answers to work with at the bedside is something we need to look at the evidence. So there is looking at the evidence, translating into a bedside practice has not been happening in the patient ventilator asynchronies. There were limitation in terms of conflicting sort of evidence, and the other thing which Laura mentioned and a bit mentioned by Marcus as well, that most of the studies have actually looked at esophageal pressure balloon, while at the bedside we use often ventilator waveforms to identify these patient ventilator asynchronies. Does it translate it to the same thing, or do we need to figure out we can use these waveforms to pick these up? The other thing is we wanted to do two new things, probably for the first time, is to build up a hierarchy, which was never possible before. Simple way to build a hierarchy is to talk to your friends and say this is first, this is second, and that's the third. But then we know in a narrative sort of or a roundtable meeting, there are a risk of a group bias, there is a risk of a conformity, and if Professor Marcus is talking, probably we will not even say anything. So that usually happens. There is a leader effect which chips in, and we understand that it's not easy to remove these biases when you are sitting in a round table. So the purpose of Delphi is to mitigate these biases, to ensure that everyone is having their voices and well heard, and it reduces the effect of the other person or your peers to affect your opinion, especially in areas where the evidence is really lacking, or you want to build up a real hierarchy, in this case, like what you have wanted to build up in a severity of you can say PVAs. So for those things, Delphi has been a proven methodology and has been existent for nearly now 6-7 decades. Mainly previously used out of healthcare, but in last 3-4 decades, it has become much more popular in the healthcare to build up these things like a consensus on certain topics where the evidence is conflicting, ambiguous, or where the chances of doing a quantitative research is not possible. So you cannot build up a hierarchy by doing a quantitative research. You need to have a certain question in your mind, and that should come through a consensus. Delphi is one of the methods to achieve that consensus. Ahmed, I think you are on mute.
I'm sorry. I just want to ask you how many rounds you did during the study for the to get the consensus.
Thanks again. This is a very, very important question because this was a very different type of a study. It was a quite motivated panelists who were quite actively into the research on patient ventilator asynchrony. We already had identified this group, which was working together for last, I would say, nearly a decade and more than a decade on patient ventilator asynchrony, or at least they were quite motivated and interested enough to build up this hierarchy. So it was a very important thing that I need to chip in purely as a methodologist and to make sure my presence as an intensivist should not affect the process. So I was not allowed to the vote, and I was the only person who was not allowed to the vote. Though we had 3 more steering committee members, including Professor Skulls, Laura, and Menon, who was our first author as well. So she did a wonderful job ensuring that there is a bit of coordination, but the only person who was allowed to see the responses was me. And to remove any biases of seeing those responses, I was not allowed to vote. So rest of the panelists were allowed to vote. The other challenge which we had in this process was basically these were sequential rounds rather than independent rounds. They were linked to each other. That's why we had 7 rounds over a period of nearly 6 months. And it was quite intense rounds because we were not reaching at certain point consensus. In fact, one of the very few instances where we had to call up a virtual meeting, but we ensure that despite those virtual meetings, the voting was done anonymously, and there were the so-called dominance and peer pressure biases were well taken care of. At the end, we actually presented everything transparently, what was happened, how did it happen, and why virtual meetings were required in this process. But it was a quite lengthy and more of say a challenging process to do this. And these were sequential round. The first one is to identify the PVAs. The second one, which you can identify through a waveform, were put into the second series of round where we actually asked them to link to patient-related outcomes. And the third one is to build up the hierarchy by looking at the severity of PVs.
Thank you, Dr. Prashant. It was a very clear answer to our questions. Maybe Dr. Ali can ask more few questions to our board.
So thank you, Dr. Prashant, for I think the methodology is very, very important, and I think the level of methodology led to the publication of this paper in a very high impact factor journal. That sometimes we have ideas when we want to do research, but we don't have a strong and robust methodology. We just fell into failure, and having a methodologist like Dr. Prashant, I think it's very precious. So thank you, Dr. Prashant, for explaining how it works. So now I just ask Laura, Dr. Laura, what are the challenges with the detection of PVAs?
Well, thank you, Ali, for this question. So I think we already mentioned it a bit, that actually detection of patient ventilator asynchronies are actually quite difficult, quite complex. It's challenging, and I think you recognize this. So, because in PVAs often appear as a subtle change in waveforms, and I'm not sure about you, but I have often discussion with a colleague which PVA it actually is. Is it one PVA or is it the other, and what can we do about it? So there is maybe some variability between clinicians and between ICU professionals, but of course it's also just hard to recognize them because we are not 24 hours observing the ventilator. We are not able to because we have a lot of other work, other priorities. So it can happen in, like 30 minutes. But in that 30 minutes, you are not present at the bedside or not present at the ventilator because you're working on another patient. So it's difficult, it's challenging. It sometimes goes away or it appears when you are not there. And
I guess as well, sorry, I guess as well, when we have an ICU patient who has so many things to fix. So if you have a patient who is on septic shock and he's not doing well, or he has brain injury and he's bleeding. So the ventilator is not always the focus and doesn't have direct consequence. I mean, it's not like hypoxemia sometimes, and you see that something is wrong, high peak pressure. So I think it's as well the problem of to be indolent. What do you think about it?
Yeah, of course, sometimes the ventilator is definitely not the first priority when you have a patient bleeding or need to start on dialysis or having a line for vasopressors or something like that. So of course it's not possible to have the monitoring on the ventilator screen at all times. It's just not possible. And well, in the end, we say it's complex, but the recognition of PVAs also requires training, education, experience, discussion between colleagues. So of course, if you're not having the possibility to do that because there's no time or the patient has other priorities to fix, then well, it's difficult to recognize them and just to see them on the ventilator. So it's a combination of multiple things. It's the workload, it's the time that you need to recognize them. It's just difficult to observe the waveforms and to recognize them because they're very subtle. So it's actually quite challenging.
Yeah. So it's a very big challenge to recognize them and to isolate them and to take care of them. So from a perspective of how to detect them from a ventilatory waveform, which one are usually easy to recognize, and which one needs advanced tools? And I will just direct the question to Professor Juliana. Thank you, Laura.
Of course.
Thank you, Ali, for the question, and thank you so much for inviting me to this webinar and organizing everything. It's a group of passionate people about, all of us passionate about mechanical ventilation and asynchrony, so very interesting discussion. Depending on expertise, I think we can train clinicians to recognize patient ventilator asynchronies, but this study showed that most experts consider that there are a few types of asynchronies that are very hard to be detected at the bedside, looking at the curves alone. And it's mostly auto-triggering when the ventilator is starting efforts that are interpreted as starting cycles that are interpreted as initiated by the patient when in fact they were not. Yeah, so that's the image that shows us. So the patient is not making an effort, but the ventilator is delivering a cycle as if it was initiated by the patient. So this is really hard to see at the bedside. And delayed cycling, when the ventilator is delayed to end the cycle, the patient is already satisfied. They're no longer making an effort, but the ventilator continues on. This is also difficult, harder to detect at the bedside. So this is what we identified among the experts. And this is also something that has been shown in the literature. So these are specifically two types of asynchronies that if you're looking at the ventilator waveforms alone, you might miss them. But I think the trick is that if you combine it with clinical data, it may be a little bit easier to detect. And I see that somebody wrote that in the chat. I wanted to address because it's exactly this topic. And they say, how do we suggest to manage? How do we see these asynchronies in lower middle income countries or in low resource settings if we don't have very fancy tools like Laura mentioned before, esophageal catheters and stuff. And I think one solution, which may not be perfect, is combining clinical signs, because, for example, auto-triggering is typically accompanied by a high respiratory rate, and you look at the patient, they don't seem to be doing any efforts, and you still see a lot of cycling as if the patient was tachypneic when they're not. And delay cycling may be the same. You see the patient making a little bit of effort in the beginning of at the end of the cycle when they are already expirating. So you see abdominal signs of the patient making expiratory effort at the end of inspiration. So combining clinical data with looking at the waveforms may be one way of doing this. And then, of course, we need to consider that maybe in the future, artificial intelligence may improve and algorithms to detect these kinds of asynchronous looking at a previous pattern. So you would have to compare the patients with themselves and the waveforms from those patients to be able to identify. And so that's a little bit more high tech and more to the future, but combining clinical data with the waveforms is, I think, one strategy to improve diagnosis at the bedside.
Thank you, Professor Juliana. So we agreed some of the PVAs we are not able to recognize just on the ventilatory waveform. So we need either clinical assessment to help to suggest that there are some, but as well we can use other tools. And which tools do you suggest if someone wants to have better detection?
Yeah, that's a great question. So if you have esophageal balloons or a diaphragmatic, the catheter we use with the NAVA mode, which detects the activity of the diaphragm, these would be typical tools you could use, because then you're seeing the effort, you compare the effort of the patient with what the ventilator is doing. These are invasive techniques. They're more sophisticated and not available in all ICUs. It can be expensive. Outside of that, I would say is combining with the clinical judgment. I think it's a good strategy, and training. I think training to learn how to identify that something is odd in the waveforms, and then looking at it carefully, looking at the patient and comparing. I find it so curious that we teach clinicians, all physicians and many other clinicians, how to read an EKG, an electrocardiogram, and everybody knows how to identify a myocardial infarction. And it's a typical waveform. It's just a change in what is normal. And any undergrad student in medicine learns how to see a myocardial infarction, but we don't teach them to recognize the same kind of trouble, which is a change in what is expected in the waveform. So I truly believe that these are patterns that can be taught. It's just a matter of changing culture to at least identify the ones that are most problematic and which you can identify at the bedside.
So you are saying that the ventilator waveforms are the ECG of intensivists. So we have to learn more, actually.
Yes, that's a great summary.
So for you, if you have to give, let's say, 2 or 3 most relevant PVAs, clinically relevant, which one you would, among we have here 7, which one you would choose and to say this one we have to recognize them?
That's a great question, because there's actually no study in the literature that has compared the impact of these types of asynchronies in outcomes. And the reason is simple. It's difficult to separate. Some patients may have more than one type of asynchronies, and you need a lot of patients, so you need a large study to look at that. What we do have in the literature is studies that focused on 1 or 2 types of asynchrony. What we know from observational studies is that ineffective efforts are the most common type of asynchrony, followed by double triggering. And also reverse triggering that can sometimes be accompanied by a disturbance that looks like double triggering is also more common than we thought. So I would say these 3, because they have been because they're the most common ones, and because they have been more studied. So we know the impact of ineffective triggering and in double triggering for patients with ARDS, and for ineffective triggering for COPD, for example. And we also know patients who have more of these synchronies, especially when they happen in clusters, when they happen together, at times where there's a lot of asynchrony happening at the specific period for a patient, have been associated with worse outcomes. So I would highlight double triggering, ineffective triggering, and reverse triggering as the top three.
And last question. Can we have in a patient that's almost same time, same, I would say, cycle in 1 minute, having more than 1 or 2 PVA?
Absolutely, yes, yes. And because some of these PVAs may be influenced by the same phenomenon. So for example, patients who have delayed triggering, which is a synchrony we don't recognize as easily, they might receive a higher tidal volume than they actually wanted or needed. And then they are hyper insufflated and then may have ineffective triggering. So these two can be happening together. Premature cycling typically happens together with double triggering. So yes, you can have more than one. And over time, you can have the same patient changing from one dynamic to another and having more of a type of a synchrony than another one. So that's why it's so complex to isolate the impact of each of these asynchronies in patient outcomes.
Thank you so much. Maybe, yeah, Dr. Denise, take care.
Yes, thank you so much, Juliana. So now I would like to move the discussion toward PVA in acute respiratory distress syndrome, so which remains crucial yet often under-recognized in daily practice. So particularly to Professor Marcus, let me ask 2 more questions. Which PVAs were judged most clinically relevant in patients with RDS? Which is your thought?
Thank you, Denise, for this question. Do you allow me to come back on the discussion that we just had? Because there are 2 things I would like to add here. From the chat, I saw that there was the question, what do we do with these PVAs that we cannot recognize? And that's a good question. It's an important question. And actually, we do not know, apart from what Juliana was suggesting, it should be placed in the clinical context. An excellent suggestion, I think. But realize that there are many PVAs that we can recognize. Actually, it is possible, and I like the comparison to the ATG Juliana was making. Actually, our study, our results are pointing the manufacturers of ventilators at something they can do. I'm sure we will discuss this a little bit later, but these PVAs can be recognized, and they can be recognized in an automated way, in an automated fashion. And I'm always surprised that I get all these alarms on my ventilator: tidal volume too high, minute ventilation too low, peak pressure too high, etc., etc. I never receive a message that there is maybe a PVA, and I really think that that should change as a start. And second, that was also nicely discussed, you can have more than 1 PVA in 1 patient, and not just more than 1 PVA, but different types of PVA. What we also have to realize is that the solution for 1 PVA could actually trigger another type of PVA. And we have quite nice examples of that, in which automated adjustments of a ventilator are causing a lot of trouble by adjusting settings or adjusting other things, only creating more PVAs, which may be worse or maybe less worse. That's actually what we don't know. And here I come to your question, Denise. What is seen as bad or very dangerous PVAs? Well, actually, I think it's still on the slide here. I think you can still see in here. It's showing in red, orange, and yellow the double triggering, ineffective triggering, and the reverse triggering were seen as the most important ones, and in this order. I can explain later why I think we came to that consensus. For the other patients, we were not able to find a consensus, or they have a consensus on which are important or which are more important. So the short answer to your question, actually, Denise, is double triggering, ineffective triggering and reverse triggering are the most important ones in ARDS.
Yeah, thank you, Marcus. What do you think about double triggering treat and lung protective ventilation in this case?
Yeah, very good question. I personally believe, and I think this is what was nicely shown in this Delphi, the panelists agreed really on the double triggering as the most threatening PVA, if you like that word. Double triggering can threaten lung protective ventilation because it can cause breath stacking, as we call it. And I think everybody knows what it is. It means that you have two breaths are delivered within one patient effort. So the patient is actually receiving a much larger tidal volume than it was intended. And in this context, that matters in ARDS, of course, because lung protective ventilation is meant to keep volumes and pressures low, to reduce strain. Double triggering can undo that goal by raising the distending pressures, increasing the risk of overdistension, Foley trauma, and eventually causing ventilator-induced lung injury.
Thank you so much for your answers. So maybe some other moderator have questions.
Ahmed?
Thank you, Dr. Ali. Thank you, Professor Denise. I just have a question to Professor Juliana Freire. We know that most of the ventilated patients, they have a heart-lung interaction. And for those patients, post-cardiac surgery, what is the most common type of asynchronous related to hemodynamic instability?
Thank you for your question, Ahmed. I think it goes also back to what Marcus just discussed about double triggering and the perception that it may be one of the most dangerous type of asynchrony. And in our Delphi, we found that double triggering and reverse triggering, which can sometimes create two cycles together and cause breath stacking, are perceived as the ones that are most likely related to hemodynamic instability. And it's because they're gonna cause hyperinflation in the thorax, and they will increase alveolar pressure. And if the pressure inside the thorax is high, we have to remember that the heart is inside the thorax and surrounded by the lungs and the alveoli. So if the pressure around the heart is greater and that heart is dysfunctional in some way, it may be affected by that. And sometimes a little bit of pressure around the heart can actually be good if you're having relaxation problems. But if the high pressure inside the thorax reduces venous return in the vena cava, then that can cause hemodynamic instability. So there's a concern that these two types of asynchrony. So if you look at the graph that you're presenting for people who don't really remember how it's a heat map. And if you look at hemodynamic instability on the left side of the figure, you see that the dark blue at the top shows the high agreement between the experts, that most of the experts felt that double triggering and reverse triggering, like right behind it, below it, were the ones that most of the experts agreed that were related to hemodynamic instability. And the auto triggering and delayed cycling are the ones we all agreed were less likely associated with hemodynamic instability. And it's mostly, so I think it's helpful when you're trying to think what that type of asynchrony can cause, is if you think about the physiological mechanism behind it. So if you're having double triggering, if you inspire and before you can expire, another breath is coming in, pressure inside the thorax is going to increase, and that can have a lot of consequences. And for patients who have dysfunctional hearts, like right after cardiac surgery, these changes they're not as resilient to changes in thoracic pressure as other patients might be. So these are the two that we worry a little bit more with hemodynamic instability in cardiac patients.
Thank you, Professor Juliana, for your answer. Dr. Ali, maybe you want to go for
Yes,
the
so
section for the research priorities?
yeah, definitely. So I think we have enough material to say that we have a lot of things we start to know, but we have a lot of things we don't know. So I just want to ask Professor Marcus, what are the most urgent knowledge gaps that we have and can lead to research now? What we need to know right now?
Yeah, thanks, Ali, for this question. I think one of the conclusions that we can draw probably at the end of this webinar is that we only at the beginning of something. So now we have some consensus on what can be identified and what cannot easily be identified and what may be important and what not, but actually many questions are popping up and are left unanswered. And that's mainly because most of the literature is focusing on small groups of patients. It's usually studies done by people that are focusing on certain types of patients or only focusing at a certain time periods or short periods. And we don't know what these PVAs really mean. And let me give you some examples where I think that we have a knowledge gap. So one of the first questions is a PVA directly causing harm? Or is it maybe just an association and not really a relation? I come back a little bit on this later on, what I mean with that. We need to understand, and we already try to give an answer to that, like which PVAs are more important in ARDS patients, which are more important in other types of patients. And let's not forget, most of the literature is mostly on ARDS. Actually, most of our mechanical ventilation studies are focusing on ARDS. But let's not forget, 80% of our patients is not having ARDS or is receiving ventilation for complete other reasons, like, for instance, post-cardiac ventilation, post-cardiac surgery ventilation. And the other thing is that I think, and I already said that before, I think we need reliable automated detection tools, either in ventilators or outside of ventilators. But I think it's really time now to move on to something that we can easily do, but just have.
We lost you, Professor Marcus. I think I don't know how we can call this PVA. It's double triggering or ineffective triggering, maybe ineffective triggering. So maybe I will ask Dr. Prashant if we have research gaps. Professor Marcus, are you back?
I think it seems he is trying to join.
Yeah. So maybe we can talk about the trials. What are trials are needed, Dr. Prashant, with this gaps that we have?
So I think one of the thanks, Ali. So I'm just chipping in this particular question for Marcus, and it's very difficult to chip for someone who is Marcus. But yeah, I will try to answer what challenges which, and these most of the research gaps which we have identified in this particular study was through the comments of panel and people like Juliana and others. They really brainstorm what we need to work on, and some of these comments, some of these research gaps were identified recurrent comments which were coming up when we were discussing how they can be linked to the outcomes. I think the most difficult part is because we do not understand some of these terms are recurring and some of them are not properly defined, or various names or nomenclatures have been used for the same term. I think it's a big gap unless we start talking a common language. It's very challenging to do research on that particular topic. I think one of the first thing which is about the nature and the scope is so-called the definition of this construct is really heterogeneous. There have been different terms which have been used for patient ventilator asynchrony, and I really believe we are working on that with Ahmed and you being as the lead on that role to have a more of a common language to speak about what is patient ventilator asynchrony and what are the common terms we should use when we talk about patient ventilator asynchrony, and another topic where a consensus is required. But other than that, we need much more evidence to validate what we did in this consensus, particularly the hierarchy itself. And I believe Laura probably, if is still there, will able to tell you that we are also working on that, trying to empirically validate. I think that was also one of the questions which was there, how we are going to say that what we have achieved through this consensus is good enough. Yes, we do not know. It's just at the end of the day a consensus from a very motivated, but at the same time a very small group. We need to empirically validate this hierarchy, and the work is already ongoing. Probably in future we will be much more better positioned that to answer that question, whether the hierarchy which we propose is really validated enough to be used at the bedside.
Thank you, Dr. Prashant. Yes, the foundation is to speak the same language, and then we can go to trials. And do you see them as more observational studies, or if we have to start, or you would like to go with some RCTs to test some intervention on some PVAs, or what's your approach, or it can be parallel?
So I think it depends on the research question, and probably Juliana, I saw her hand is already up. So she definitely has much more expertise on that. But I believe talking about that research question is going to decide what type of methodology would be appropriate. Like for developing a classification, I still believe consensus is a better approach to start with. But for empirically validate observational or a randomized control trial, you cannot finally validate through face validation, which we did. That was to start with, but eventually it needs to be prospectively validated into a large observational study, or probably followed by a randomized control trial.
Thank you. Juliana, you have a question.
I wanted to support Prashant when he was invited to comment, and Prashant did a great job summarizing the research gaps that we listed on the publication. There are many, and it's not because it's not a topic that has been the interest of many researchers. I think one of the biggest challenges is that for many things we want to know about asynchronies, we cannot use randomized controlled trials. So we cannot randomize patients to have or not have asynchronies. It's impossible, impractical, and even if we could, it would be unethical. I think we have been very limited by the fact that most of the studies are observational. Having said that, I think there are many clever ways of trying to separate things and looking at new nuances in observational data to try to identify specific aspects of the asynchronies that we still don't know. And then, of course, a randomized controlled trial would be, as Prashant just mentioned, interesting if you want to test a strategy to. So what if we decided that we would randomize patients to have someone try to correct the asynchronies at the bedside, identify and fix, or just let it be? I think there are also challenges on how to design a trial like that and keep it ethical and equipose. But also trials in mechanical ventilation have been proven to be very challenging because it's easy to randomize people to get a drug, yes or no. But when you need to come at the bedside and make an adjustment in the ventilator, sometimes when you make the adjustment, other things happen. And Marcus mentioned that before, you're making a change to improve one type of asynchrony, but that change causes another type of asynchrony. Then what do you do? So that's why I think it's not impossible, but really challenging to do interventional trials in asynchronies, and they haven't been tested. I think the only one that comes to my mind is a trial randomizing patients to receive the NAVA catheter and NAVA ventilation instead of pressure support, which was a trial that showed no difference because there's so many other things happening. So it's a big challenge, but it doesn't mean we can't do what researchers like challenges. So I think what what we intend to do as a group, and many people here looking into projects in asynchrony, trying to understand a little bit better what we can take from the observational trials, and then think what are strategies that we could apply as interventions in the future.
And thank you, Dr. Juliana. We just have a minute of silence for the Dutch National Remembrance Day in respect of Dr. Laura, who is part of our group. And this minute of silence commemorates all civilians and members of the armed force who have died in wars of peacekeeping missions since the beginning of the Second World War. Thank you. Just 1 minute.
Thank you, Dr. Ali. You can continue.
Thank you, everyone. Thank you, Dr. Juliana, for your comments. And I think it's very important to say that going to test any intervention in PVA will be challenging. So to do an RCT in such kind of patient is not easy. And I would just give a chance for Professor Marcus to intervene, because he was out of he lost connection. So please take the voice.
Yeah, thank you, Ali. I think I was having a sort of Wi-Fi user asynchrony or something. Very annoying, I can say. I think it may have been discussed already, but I started with saying that we are just at the beginning, and we are doing now several studies, or there are several new studies that start, like the ProVent Trace by Juliana, who's going to look at different groups of patients across the world, especially trying to understand when PVAs occur, not only focusing on a certain time frame, but actually on a longer period of time. And it could very well be that early PVAs are more or less important than late PVAs. A same initiative is taken in children, the ProVent PET, which is also a study done by the Protective Ventilation Network, but now entirely focusing on children, where I can say that there are a lot of PVAs that are simply because the ventilators are not made for children while still being used in these small patients, causing the typical PVAs you then expect. You can guess which one those are. And finally, it's important to get the right nomenclature so that we all speak the same language. And this is where Ahmed steps in and is doing his own Delphi quite soon, focusing on this topic. I do think, and I already said it before, I think that automation is here to help us. And I think it's actually very well possible. So when I said, why is my ventilator not alarming when there are certain types of PVAs or any PVA, that's strange, right? That should change. And making automated corrections is also very well possible. But the difficulty with these randomized clinical trials you were talking about is, then what should we focus on? What is the association exactly? Is it related to mortality? Is it a causal relation, or is it just an association? Should we look at mortality or duration of ventilation, or should we look at more subtle endpoints like patient comfort to start with, like in this patient group we were having interest in our Delphi, the patients after cardiac surgery, there was a lot about patient comfort actually. And a lot of the PVAs, if not all PVAs, were seen as very important for patient comfort, or to improve them to have a better patient comfort. So, and I repeat myself, I realize, but we are just at the beginning. We need to many steps, and I think the Delphi helped us in identifying what can be identified at the bedside, what can be used, and I really hope that the industry is stepping in, helping us with these sophisticated tools to recognize, alarm us on a constant level, and then maybe step into randomized clinical trials. But that will take quite some time before I dare to step into one, because I really don't know at the moment what to do with the randomized clinical trial. Giving back the word to you, Ali.
Yeah, thank you, Marcus. I think it's a very valid point. I think it's just the beginning of science. I mean, science related only to this interaction. I mean, so many years and decades we have mechanical ventilation, but it's interesting that it took so much time that we start to focus on that, because we were discovering the pressure and so on. But now we look at the time related to this to this interaction between patient and the ventilator. I have a last question, and I think it has been as well requested by many attendees, because we are in the era now of AI. Do you think AI, Dr. Laura, Dr. Prashan, do you think AI can improve the recognition and management of PVAs? And do we have already something ongoing, some research or some new devices coming soon or already available to use AI?
Answer to your second question, whether the research is going on, probably Professor Scholes would be better aware about it. To my knowledge, AI is going to help, at least for detection process. And I see Laura is back. Probably she would also be able to answer this one. But yes, I understand artificial intelligence probably will have an important role in detection. Will it be something which will help us to, guide us for the treatment? I'm not sure still whether we would be able to, because there are still a lot which has to be answered. And if we do not know what are the right answers, so it's very difficult to train a model on something which is known for at present to unknown for us. So that, if you are unsure of a certain thing, when you are preparing a model or a machine learning, they are more likely to be failure, because the answer to them is also going to be answered initially by the humans.
Yeah, the question as well goes with the time. I think one of the attendees asked question about everyone is busy in the ICU, they don't have time, and as you say, it can be subtle, and how we can improve the recognition is like, if you look at the blood pressure, if we use only the cuff pressure, we miss a lot of hypotension. So now you have a continuous reading of the blood pressure with the invasive arterial line. So here we can say maybe that AI can be a kind of continuous monitoring of AI using this technology, machine learning. So do you think we need to start from now and not to wait too long? Because maybe we might spend so much time in research that actually AI can detect and to say, okay, this type of, we have 20% in patients who are from cardiac surgery with PVAs, and actually such type are more frequent when they come from this type of surgery and they have bad outcome, than to have someone in front of the ventilator trying to get all the PVAs. So that's in that way, I think, I think it might be interesting.
Yeah, I agree. I think Marcus also has something to add to it.
Yeah, please, Marcus.
Yeah, my question back to you, Ali, would immediately be, what is exactly AI and how should we think about AI? And I'm definitely not someone who is doubting the value of AI, but I think we have to step back a little bit and first try to understand what we're really looking at. That's the question. What does a PVA actually mean? And what does a certain PVA mean? Does it help to treat one PVA maybe with the risk of getting another PVA back? And what that then mean? Maybe AI is going to help us here, but the culprit, I think, the problem that we have at this moment is that there is poor recognition, poor detection, and I think, and I like to use this word actually, a lot of these things can be automated. Automated recognition, looking at waveforms through the ventilator. So the software in the ventilator can actually look at the waveforms and can do a better job for many reasons. It can look at more subtle things. It can recognize subtle changes in the waveforms, and it's there every breath. It's not just there when the doctor is passing by in the morning and say, hey, I see a PVA, or when the researcher is passing by in this hour, he or she wants to collect PVA. It's doing it on a constant basis. We have some examples in the literature. One example was already given, that's using a NAVA catheter with maybe some sophisticated software. We also have IntelliSync, which is deliverable on some of the ventilators of Hamilton, and they can do a good job. But interestingly, and this is what I was referring to, by solving some of the PVAs, it was also inducing new PVAs. And interestingly, it was working well in one patient group, but it was doing a very bad job in another patient group. So it's all about detection, automated detection, then maybe finding solutions for that. And then maybe we can step into AI, but we have to supervise the model, if I say this in a correct way. I'm not an AI specialist, so I have to be very careful how I frame this. But we have to give answers first to many questions before we can step into AI.
And you are not scared, Marcus, that with the pressure of the AI now will be pulled. You will not have time to say no, I will not use AI. So and people will produce data soon with AI before we can have. And actually, this new AI data will give maybe some new insight about the thing. So I'm still doubtful that we can take our time because everything is going to AI now.
Well, you know, I'm not really afraid of that. First of all, I think if they can do a very good job, be my guest. I would be more than happy if they step in and say, I have the most perfect solution for you. And it's even a solution for a thing you didn't know you were having a problem with. But that's not the case. We know what we're talking about, or at least we understand a bit what we're talking about here. And I think here it's where the clinicians, like the people, the panelists that we had on board of this Delphi, come around the corner and say, wait, you can maybe try to solve this, but that's maybe not such an important PVA, a patient ventilator asynchrony. Maybe you should focus on something else. And we have some experience in this respect, talking to some of these industries that come with solutions which just sometimes make us a little bit laugh, like this is not the solution, or this is not how it works. This is not really that important. There are other things that are more important. But again, you know, if we are taken over by AI and they are solving our problems, even those we were not even aware of, be my guest. That would be great.
Yeah. Thank you so much. Anyone has any question? I think we talk about. Yeah, we have Dr. Mohsin saying any AI tool is only as good as the data is trained on it. It might be something to work with unified language and recognition strategy before AI comes in. Certainly, we have to look anything other than just ventilator data, and we'll have to correlate all this with changing physiology and outcomes. It's one of our colleagues from Qatar, and he's very into AI. And yeah, we have a lot of comments. So there is a balance about AI, how where to use it and how to use it. And I think that will be a very exciting time now with the PVA definition and how to recognize them, how to train the people, how will be the best way to train the people, different PVA in one patient. And we are not yet at the level of treating the PVA. If I understand from this meeting today, from this webinar, we have to understand more about it before we are going to treatments. I know some studies and people saying we can use some modification of ventilation, increase the PEEP, try to sedate the patient sometimes. So there are a lot of studies and hypotheses, but we don't have yet, I think, strong validation and evidences to do any of them. Dr. Alura, want to intervene maybe?
Yeah, well, I really like this discussion because it highlights a lot with what we do not know and what we would like to have. So yes, I think summarizing is that we are now trying to find the best way to detect. And yes, automated detection can be a possible solution. But going further and treating PVAs, yeah, is a very interesting next step. But we are not there yet, I think, as Marcus already mentioned, and I totally agree. I think the detection is really a first big step and could be much more improved. So if, well, getting back to the discussion about AI, if you think that automated detection is a part of AI, then yes, that's a step. But if you are thinking AI is something like supporting decision making on how to treat the PVA, that's really not possible because we do not know yet how to treat and how to reduce PVAs.
Any other, Dr. Ahmed?
I just want to emphasize on the value and the impact of education regarding the patient-ventilator interaction and asynchronous on the outcome of the mechanically ventilated patient during the ICU stay. Maybe Professor Marcus can give us his feedback about this topic.
Yeah, thank you. I think this is an excellent point. Actually, I thought this was maybe something for the other panelists to answer. As was nicely said already, sometimes these PVAs, recognizing PVAs, is depending on the clinical setting and understanding why a patient is developing PVAs or is at risk of having PVAs, or understanding the meaning of PVAs. Let me give you a very simple example. I was involved in the analysis of a study in children where the only intervention that really helped was just pull out the tube, because the patients were having PVAs because they were fighting a ventilator that could not ventilate them adequately. This is a very simple example, of course, and it's definitely not the solution for all the other PVAs that we are talking about. But as Juliana already said, I think it's very important to understand the clinical context and have better education in that respect. But maybe Juliana wants to add something here.
I think Professor Juliana, she left. What if we combined the AI detection along with the education?
Is that a question for me, Ahmed?
Yeah.
Well, I think you can give an answer in different ways, or you can try to. I can give an answer to this question in different ways, but one of the things I was thinking about is that using automated detection, alarming at the bedside that the patient is having asynchronies, and how to understand how you can treat them is already a part of education. If you're not aware or made aware that your patient is having asynchronies, then you are completely blind. And we are now maybe half blind, that we understand something and that we want to do something, but you remain completely blind if you don't know what's happening actually with your patient. And then this is already something which is part of education in my way of thinking, that you get a better signal, that you maybe get numbers on your ventilator, or that you get reports in your PDMS about your patient over the last hours. What happened here? And we might not be interested in tidal volume anymore. We know tidal volume should not be too high, or maybe in areas patients should stay low. And we know that driving pressure is important and that it should stay low, or that we should try to keep it low. But there is nothing about PVA, and having a better understanding of the amount of PVAs in your patients and the types of PVAs is already education, helping you to take more proper decisions. Not even knowing what the best decision is then, but at least you are aware and you know you have to do something, or you have to try to do something.
Thank you, Professor Marcos. My question to Laura. You have a good experience with deep breath as an automated detection for the asynchrony. What's your feedback?
Well, we have been using this retrospectively with collected data from the ventilator. So we collected waveforms in randomized studies, and we used the software of deep breath to to analyze the amount of asynchrony. So we used the software, and we literally put the data from the ventilator in the software, and we received another file where the incidence of asynchronies were analyzed, and the types were specified based on their algorithm. The algorithm of deep breath is in development. They are continuously improving it. That's also a part of AI software. It's a model that has been training itself, but also with new data. So that's it's a good experience. It's very interesting to use those retrospective data. And a second project we would like to work on with our group is having in a small pilot an automated detection at the bedside. And that has been proven challenging, and that is mainly because of practical challenges, because you are we want to have a device or a tool from deep breath attached actually to existing medical devices. And medical devices are, of course, as you know, highly regulated, and there are a lot of safety rules into hospitals. So we want to have that in a safe way, of course. So those are challenging, that are not solved within 1 week. That takes time to have it implemented in a safe way in an already existing hospital environment. But we are not afraid of challenges, of course. So it's a project that we are working on.
Thank you so much.
Thank you so much, everyone. I think we'll close the session to give room for everyone to go back to their activities. I think it's really great and a lovely meeting that we had today. It's about again PVA, and thanks to the PROVE network, to the PVI network, to the Critical Care Network African Middle East, to the speakers and authors of this SYNAPsE Delphi Consensus Study, and to my colleagues who were moderators. Really, we are happy, and that the beginning of that, we are creating a community around these PVAs, and that's very important that we have more and more people involved in that and educated, and then we can do more research and give better care for our patients. Thank you, everyone, and I wish you a good evening.
Thank you.
Thank you very much.
Thanks a lot.
Thank you.
Thank you.
Thank you so much.